Hey everybody, so this is going to be your lecture video over Unit 12. Let's go ahead and get started. So Module 12, sorry, I always call them units for whatever reason. So just a quick review of the different like bony landmarks and body parts. You don't need to know every single muscle because we're not going to stretch and work with these as individuals. We're going to mostly work with them as groups. So just know the different muscle groups and the actions of those muscle groups. So you know which ones internally rotate, externally rotate, flex the hip, all those different things. Do know your special tests over the hip. And that's really kind of it from there. So common pathologies of the hip, avascular necrosis. This is just, it's one of the most, it's not, well, it's a common cause of hip replacement surgery. The blood supply to the hip just gets damaged either through a fall or an accident. This is what happened to Bo Jackson, the NFL running back, which you guys may or may not remember him. But it can also be caused by diseases, or people can even be born with some congenital conditions, steroid use, alcoholism, lots of different things can cause it, but it's the lack of that blood flow to the inside. And so this is what it causes. The femoral head just begins to necrose or die and fall apart. And so they have to go in and completely replace the hip. Greater trochanteric bursitis is just over the trochanter under the IT band is a big bursa. If you're overusing the IT band, that bursa underneath it can get swollen and inflamed. Sometimes it can be something weird, just like an infection even, that settles in that bursa. They'll have pain over the lateral laterally over the greater trochanter, and it'll kind of really be super painful right there, and then it'll kind of run down the leg. So you have to just kind of stretch the IT band, do some ultrasound and icing to right over the bursa and kind of treat things. Here's some videos, some different exercises, but IT band stretches, strengthening of the adductors to kind of balance things out, and then just trying to get that inflammation down is really what you do. Hip fracture, the most common bony injury, the most common break are fractures of the hip. They can happen here at the neck. They can happen between the different, this is called an intertrochanteric fracture. It starts from one trochanter and runs all the way through the other. Sometimes they're lower here, and it's the, the top of the femur before we get into the, you can even have them just right at the head. There's a lot of different fractures. So what happens here is they either end up replacing the hip, or they will come in and put a screw and a plate in to kind of fixate everything. You'll see patients not right afterwards, but as soon as they've healed to the point, if it's a hip replacement, you'll see them almost immediately. But once the break has healed, then you'll start working with them just to restore weight bearing, restore walking, figure out why they fell in the first place, and deal with their balance. So just make sure you're following any precautions they set for patients like these. Make sure you're strengthening the whole joint around them, moving through that progression of passive and then isometrics, and then moving into active assistive and active range of motion and strengthening. Hip osteoarthritis or degenerative joint disease. When we get older, usually osteoarthritis, the bones just begin to break down as we get older, and the labrum and all this, the capsule, the joint capsule itself begins to break down. Even the bones inside can start to break down, and it can cause lots of pain. Osteopenia, this is it's before osteoporosis. Like, we go through stages as we start to not have enough calcium in our body, our bones become less dense. You just need to be aware of that because it's one of the big reasons people end up with hip fractures. Um, Piriformis syndrome is when you have a tight piriformis, because the sciatic nerve runs through it. It can actually literally pinch that sciatic nerve, and so they'll get that peripheralization that we talked about earlier, and they'll think something's wrong with their back when it's really just that they have really tight external rotators. So you want to stretch the piriformis and strengthen the internal rotators to kind of pull and lengthen this muscle and kind of balance things out. So no, piriformis syndrome is something you'll see quite a bit of, and here's a good video on how to treat it, but it kind of goes over. It's pretty straightforward. Sciatica. So piriformis syndrome can cause sciatica. That's just that radiating pain down the nerve. It can also be caused by a herniated nucleus pulposus. Um, uh, and other situations as well. Usually it's a herniated nucleus pulposus or piriformis syndrome. Um, Sacroiliac joint dysfunction, we've talked about it actually a little bit in the last one, when the sacrum and the ilium of your pelvis kind of get out of alignment, right? It can cause a lot of pain, usually right at the gluteal cleft and where those dimples are on the low of your back. You'll have really a lot of pain down there. Sometimes it can even kind of radiate down a little bit. And so there are things we can do to kind of get those lined back up. There was a video in your last unit about that. And then finally, total hip replacement. I am pretty sure you guys have talked about that some with Jennifer's class. Just go over this again, make sure you know those precautions, especially for the posterolateral approach, because it's the most common. But also be aware that sometimes they do also an anterolateral approach. So the precautions will be a little bit different for that. From a PT standpoint, usually they're up and, from a Therex standpoint, usually they're up and walking that day. If not within a few weeks, they definitely are. And so your goal is just to get them up, get them walking, get that joint strengthened and the muscle strengthened around that as much as you can. Teach them their precautions and make sure that they're following those precautions, and make sure that any strengthening that you are doing with them doesn't violate those precautions. It's pretty straightforward. This just goes over those hip precautions again. Not much there, really. So this just talks a little bit again about how to treat anterior pelvic tilt. I don't know why it goes over it. It does go over some good strengthening exercises though, gluteal sets. All this person is doing is basically squeezing their butt cheeks together, holding it, and then relaxing. It's a good isometric strengthening exercise for beginning. You can also do isometrics of the hamstrings where you bend your knee just a tiny bit and kind of dig your heel either into the ground or to the bed, where you're firing those hamstrings. Those are called hamstring sets. Hip adduction. This is another good isometric exercise. You can put a ball in between your knees and just squeeze it. It's a good way to strengthen the adductors. You can do a pillow. You can do just about anything in between your knees to kind of squeeze it. Straight leg raise. This is a good way to start strengthening the hip flexors and quads once they've kind of progressed a little bit. So just keeping their leg down and lifting it straight up. They don't even have to lift it, super far. Three-way hip exercises. You can use a TheraBand. You can tie it into a door. You can have them step on it with their other foot, right? And they go flexion, abduction, and extension, which we see here. Some really good exercise as they progress and move into that more chronic stage, and they're a 3 or maybe a 3+ or more actually. Um, so gluteus medius exercise, if they're having Trendelenburg gait where one of their hips is kind of dropping as they put their weight on it, this is a good exercise to focus on gluteus medius. These are pelvic drops, right? Where they stand on there and they kind of drop their foot down and then bring it back up and try and get their pelvis aligned back properly. Here's one of many piriformis stretches, right? So there's she's stretching um, the piriformis. She's stretching the left piriformis here. Iliotibial band stretch, one of many different ways to stretch that IT band as well. He's stretching his right IT band here, puts one leg behind and really pushes and leans into it. TFL is connected here, IT band goes all the way here, and we're just making that longer. Also, for those who do have total hip replacements, if they did that posterolateral approach that we talked about, they're given a wedge, an abductor wedge, keeps them in abduction, keeps them from accidentally crossing their legs while they sleep. So you will see some of those as you do your treatments. And this is just kind of if you want to read over it, there's not gonna be any questions on any tests over this or anything. But if you would like to kind of just read what an actual eval looks like for somebody who's had um, some hip issues, here's that to read over. And I think that's all of Module 12. So I know this is just a quick run through. If you have any questions, please let me know. Also, your book can give you way more in-depth details, but I'm here to help if you need it as well. So